Andrew.
Okay, it's 2 o'clock. Hello, everyone. Thank you for joining us today. We are back. Actually, we are very excited to have you all here. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all for joining us today. My name is Aline Serfari, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me since 2021. Our guest speakers today are Dr. Bennett Taye, Dr. Thiago Batista, and Dr. Hamza Alzai. This session will focus on infection. Can I hear an echo? Do you hear something? Okay. The speakers will present their cases, and at the end, we'll have a Q&A session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. And just a quick reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material is illegal. We thank you for your understanding, and with that, Hilary will kick off the session.
Hi, good afternoon, good morning, good evening. I'm Dr. Humans, and it's my great pleasure to introduce our first speaker, Dr. Bennett Taye. He's a musculoskeletal radiologist working in Addis Ababa, Ethiopia, and assistant professor of musculoskeletal radiology at Addis Ababa University, where he completed his diagnostic radiology and musculoskeletal fellowship in collaboration with the University of Toronto. Dr. Taye is currently the musculoskeletal imaging head of Addis Ababa University College of Health Sciences, and is practicing musculoskeletal radiology at the university and private diagnostic centers. His clinical interests are musculoskeletal, ultrasound, and rheumatology imaging and infection. Okay, Bennett, share your screen. Bennett, turn your audio on.
Okay, sorry. Thank you very much, Hilary, for the kind introduction. Thank you, Aline, Hamza, and OCAD for having me today. So I'll go to my case presentations. So my first case is a 34-year-old male with progressively increasing left posterior thigh swelling of 5 years duration. He is a cattle herder in the rural area, Ethiopia, and he consumes raw meat, which is kind of traditional here in Ethiopia. He had history of surgery 5 years back with early recurrence. On physical examination, he had non-tender fluctuant swelling in this left posterior thigh, measuring approximately 30 by 20 centimeter, and he has no neurologic deficit. Labs were normal, and chest X-ray and abdominal ultrasound are all normal. So on imaging, what we have is on T1 and T2. As you can see, we have a large intramuscular left thigh mass, which is multivesicular, as you can see with internal different sized round to oval cystis, and there is iso-intense or intermediate intensity material between the cysts. And on T2 axial image, as you can see, there are membranes inside the cystic lesions, as demonstrated by the arrow. So this is a post-contrast MRI of the same patient showing this multivesicular cystic mass. And as you can see, the mass doesn't show any enhancement inside, and the internal cystis doesn't show any enhancement. However, he has they have peripheral rim enhancement, as you can see on the axial and the coronal images. So these are the differential diagnoses that we can consider for these intramuscular space-occupying lesions in general. So the first one is soft tissue sarcoma. So soft tissue sarcomas generally have, we expect enhancement, some form of enhancement inside the lesions. Sometimes it can be diffuse, or sometimes they can have necrotic central regions, as demonstrated by the first image. And other, for any intramuscular space-occupying collections or cystic lesions, we can consider hematomas. So this patient had trauma, and he had this lateral thigh intramuscular mass that is T1 hyperintense, T2 hyperintense. This was a subacute hematoma, post-traumatic. And other is, for any intramuscular collections, abscesses should be considered as a differential diagnosis. So here we have a posterior lower thigh subperosteal abscess. And usually these abscesses have this peripheral thick rim of enhancement with surrounding soft tissue edema. And sometimes if the cause is secondary to osteomyelitis, as you can see in this patient, we can have these intraosseous abscesses. And the last one is cysticercosis. I couldn't find image from my collections because we don't see cysticercosis in our country, as this is a parasitic condition caused by a Tinea solium, pork tapeworm. So here we don't have the habit of eating this pork meat, so we don't see that much cysticercosis. Sorry. So I brought it from the website, and they usually present as cyst with eccentric scoliosis. So none of them have similar imaging manifestations with our case, which was multiple cystis inside a large cystic lesion. So the actual diagnosis for our case is intramuscular hydatid cyst, evidenced by large cyst with multiple daughter cystis, and membranes inside the cyst, or what's known as water lily sign, and also the peripheral thin rim of enhancement. So based on the MRI diagnosis, the patient was put on neoadjuvant chemotherapy few months before the surgery with albendazole, and the multi-compartmental cystic masses were then removed, and the wound was washed with saline, cleaned, and drainage tube was removed after 72 hours. And then he was discharged with post-operative albendazole. And diagnosis was further confirmed by histopathology, and the patient is still on follow-up, and there is no recurrence so far. So this was the surgical specimen showing this the contents of the large cystic lesion, multiple daughter cysts. So another case of a 28-year-old male, he presented with progressively enlarging left posterior neck swelling. And on physical examination, he had non-tender posterior neck mass with normal overlying skin, and labs were normal, chest X-ray, abdominal ultrasound didn't show anything. So on imaging, on T2 weighted image, as you can see, we have suboccipital mass posterior to the C1 to C3 spinous processes in the paraspinal muscles, posterior paraspinal muscles. And the mass has, as you can see, multivesicular with multiple internal cystis. And surrounding the cystis, there is an intermediate signal a collection or fluid surrounding this cystis, and with hypointense T2 hypointense ring. And on T1 coronal and post-contrast, as you can see, the cyst doesn't show any enhancement. And actually, in this case, we don't see even peripheral rim enhancement. And the central cysts are relatively T1 hypointense compared to the mother cyst. So the same differential applies here also. Soft tissue sarcomas, hematomas, abscesses, or cysticercosis. And the actual diagnosis here is also intramuscular hydatid cyst. So with this diagnosis, the patient has surgery. And as you can see, large cystic mass was removed. And the contents, as you can see, show some collapsed and non-collapsed daughter cysts. So this was a case of two cases of hydatid cyst. Just for summary, hydatid cyst is a parasitic disease caused by Echinococcus granulosus. It's a tapeworm. And usually we see it on farm workers who have these livestock. And the dogs are a definitive host where these gravid larvae release their eggs. And the sheep, including humans, are intermediate hosts. So in humans, these these eggs will hatch to form larvae, and the larvae will penetrate the intestinal walls, go through mainly through the portal vein, especially they go to the liver and the lungs. These are the common sites, especially the liver is a common site that we usually see here. And sometimes they can spread through the systemic circulation into other organs and muscles. So intramuscular hydatid cyst is not common. In fact, it accounts for less than 3% of the cases, according to research. This is due to the fact that there is, as you know, muscles use anaerobic type of metabolism, producing large lactic acid. And this lactic acid is inhospitable for the hydatid cysts. And the contractility nature of the muscles also make it unsuitable environment for these cysts. We can have serology. We do serology here, especially the antibody, the ELISA tests, but they are non-specific. They have high false negative rates, especially in endemic areas like in East Africa. So just a summary of the contents of the cyst. So this is just, sorry for my asymmetrical drawing. So the cyst has basically three walls. We have the pericyst. The red one represents it's not made by the worm, the parasite. It's by the human fibrotic reaction to the cyst. So it contains fibroblasts and blood vessels. So this is the one that can show enhancement on MRI because it contains the blood vessels, and it has fibrous tissue. That's why it can get this hypointensity on the T2 weighted image. The ectocyst is a cellular membrane made by the larva, and then the endocyst is the one that produces this daughter cyst and scoliosis. So inside the cyst, we have a fluid, what we call the hydatid sand. And inside this, and in between in the fluid, we have multiple daughter cysts. And in the fluid, we can have these parts of the cyst, like the scoliosis, the hooklets, and it can have many contents like polysaccharides, lipids, proteins, and which are really, if they are released, they can be the antigenic and they can cause anaphylactic reaction. So ultrasound is a good modality as an initial modality. And what's typical on ultrasound is this, what we call double wall sign. So as you can see in the zoomed image, we can see these two walls. So the outer thick wall is the pericyst, and the inner thick wall is the ectocyst. And the content, it's not usually purely anechoic. It has somewhat internal what we call hypoechoic ecotexture. That's due to the hydatid sand. So in summary, what we see on ultrasound include double layered wall, daughter cysts, floating membrane, and hydatid sands. On CT scan, we can see calcifications better, and we can see still the daughter cysts, and especially CT scans are better for, especially when we consider musculoskeletal hydatid, they are better than ultrasound for intraosseous hydatid. MRI is the most specific and sensitive modality. It's very good to see the anatomic extent and to better describe the lesion. And as we saw on our image, they contain these multivesicular lesions with multiple daughter cysts, seeing these floating membranes, what we call water lily sign, peripheral enhancement makes the diagnosis easy on MRI. And intraosseous highlighted is also better seen on these cross-sectional imaging modalities. So the treatment is usually, especially for large lesions, it's surgical excision. So it's aimed at removing the cyst entirely. So we have to be careful. So that's why the value of MRI or imaging is here, is to diagnose the condition before surgery, so that we don't, the surgeon will be careful not to release these contents into the surrounding tissues, because these contents, as I've said before, they are antigenic and they can result in anaphylactic reactions. And pre and post-op albendazole is said to help for recurrence not to happen. So in summary, the take-home message is one, intramuscular highlighted can mislead to other soft tissue tumors. So it's an imaging diagnosis mainly, and it should be considered in any cystic mass, especially in patients from endemic regions. And ultrasound and MRI are very pivotal for the diagnosis. And we have to be careful in aspiration of these cysts and in surgery, not to inadvertently rupture the cystis, because they can produce anaphylactic reactions. Thank you very much again for the opportunity.
Thank you, Bennett. Beautiful cases. Now, our next speaker is Dr. Tiago Batista. He is a Portuguese neuroradiologist currently working at Hospital CUF Tejo in Lisbon. He's the coordinator of the imaging department at this hospital and the clinical lead for neuroradiology at CUF hospitals. Tiago Batista completed his Master of Science in Endovascular Neurosurgery, Interventional Neuroradiology at the University of Oxford in 2011. He worked as a consultant neuroradiologist at Oxford University Hospitals, NHS Foundation Trust. He's recognized for his pioneering work in introducing AI algorithms at CUF hospitals for imaging evaluation. Tiago Batista is also a member of the Young ESR Committee of the European Society of Radiology. Please, Tiago, take it away.
Thank you, Aline, and thank you, Aline and Hilary, for the invitation. And I'm very proud and happy to be here with you today. I'm going to share my screen. I hope it works well. Yeah, I guess you are already seeing it. Okay. So my case today is a neuroradiology case, but I think we can integrate it in the MSK cases as far as it's a case of lumbar infection. So we have this 85-year-old male retired lawyer that attended an outpatient neurosurgery clinic due to progressively worsening of dorsal lumbar pain with 2 weeks duration. There were no fever or associated chills, no sensory motor complaints of the lower limbs, and there was a history of L2, L5 spinal fusion in 2015. The physical exam was unremarkable. This patient is 85 years old and has a long list of diseases, specifically atrial fibrillation, arterial hypertension, type 2 diabetes, dyslipidemia, overweight, and also he's doing a list of medication every day. Going back to his history of the lumbar spine, in 2015, he started complaining of lumbar pain and also lower limb weakness. And he performed this MRI that shows a diffuse bulge at L2, L3, L3, L4, L4, and L5, and also thickening of the ligamenta flava. These were determining some spinal canal stenosis, and with this tortuous anatomy of the descending nerve roots. By this time in December 2015, he was treated surgically, and there was some spinal fusion between L2 and L5 with screws and rods, and also some devices in the vertebral spaces. This is the CT scan after surgery, showing that everything was okay, the screws were okay, and the rods also fine. And the patient was actually doing quite well. In December 2015, when he was operated, he gets much better, and he stayed like that for 9 years. But in August 2024, very recently, he started the pain that brought him to the outpatient clinic neurosurgery. By the time he did an MRI scan, which showed quite expectable findings for a post-surgical patient of 85 years old. But there was some slight hyperintensity of the disc at L1, L2, so above the intervention area, and also some edema of the vertebral bodies of L1 and L2. Also, there was some kind of edema, we might say now, of the perivertebral space, mostly on the right side. So this was not completely a sign of alarm as far as the complementary diagnostic exams were quite unremarkable. So no changes of the leukocytes or other inflammatory parameters that would be a red flag for spondylodiscitis. However, the patient was not okay, and 1 month later he came back for another second MRI, and there was an increase of the signal intensity on T2 of the disc and also of the vertebral bodies, and also there was an increase of the edema and the inflammatory changes around the vertebra, and also extending into the posterior aspect of the vertebral of the spine. And also there was a thickening of the dura at the level of the changes in the intervertebral space at L1, L2. So this was very suspicious for spondylodiscitis. So the patient went for 2 blood cultures that were actually negative. So a CT biopsy was performed, and trying to obtain some material that would help us identifying the pathogen. But unfortunately, nothing was actually growing in the culture. So this CT was not at all useful. But we know that only up to 2/3 of the CT-guided biopsies are actually useful, and sometimes we just don't know what is the cause for the spondylodiscitis. So this patient went into empirical antibiotic therapy, and he did quite well. So he started getting better, less pain, and was discharged home. So in this situation here, we are in the case of spondylodiscitis that happened 9 years after the initial surgery, and also not at the level of the surgery, but above the surgery. There are some cases of similar cases reported and described in literature. But if we talk about spondylodiscitis, we know that the incidence after lumbar discectomy is quite low. It varies from 0.2 to 4% after surgery. And we also know that if there is spinal fusion and instrumentation, that risk of spondylodiscitis can get into up to 35%. But still, there is something that is not very common. And specifically, it usually occurs within the first months of surgery, so within the 3 months of surgery, where late infections are very extremely rare, but they are described and they can happen up to 8 years after surgery. We know that spondylolisthesis is usually a result of surgical site infection, but they can also occur, as like in this case, adjacent to the level of the initial operation, what we call the adjacent segment disease. We also know that after fusion, the adjacent segment disease can be caused by degeneration that happens at the levels that are still mobile next to those that are very rigid and fused. And also that the more levels that are fused, more stress is made and applied up to the free segments. So this rigidity that happens when there are longer fusions may accelerate the mechanism of degeneration of the adjacent levels. But why there is a kind of more that might be more prone to have an infection at the level of L1, L2 on this patient when he was treated between L2 and L5. Well, probably what happens is that the stress that I was just describing at the adjacent level might reduce or disturb the blood flow at the end plates. And if there is, and if it happens that there is some bacteria in the blood, then it might be more difficult to deal with these bacteria that are adjacent to the level of the infection. Well, basically, there is no clear reason to understand why these kind of infections occur next to the fusion level. But this looks like a reasonable explanation to that, as far as we need blood to reduce the probability of developing an infection. So in this case, I would like to illustrate that spondylolisthesis rate is low and usually happens within the first months after surgery. Late infections can also occur, and we should not forget that late infections can occur as far as we need to act promptly. And also that pathogen identification might be difficult, even with CT-guided biopsy. And also that polysegmental fusions of the spine may favor adjacent segment disease, specifically infection. I'd like to thank you for your attention, and I hope this case has been illustrative and educative. Thank you.
Thank you. That was a fabulous case. Let me just ask Hamza, are you ready to go? We were having some technical difficulties. Talk to me. Hamza? Well, I'm going to go ahead and introduce Dr. Hamza Alizé. He's an assistant professor of radiology at the University of Pennsylvania and practices pediatric radiology at the Children's Hospital of Philadelphia and musculoskeletal radiology. He completed a postdoctoral research fellowship in musculoskeletal radiology at the University of California in San Francisco, followed by diagnostic radiology residency at the University of Texas Health Center in San Antonio, along with a clinical fellowship in musculoskeletal radiology at New York University Langone Health. Hamza has a special interest in pediatric musculoskeletal imaging and is the co-director of a hybrid pediatric MSK fellowship organized by Children's Hospital of Pennsylvania and the Boston Children's Hospital, the Children's National Hospital, and the World Federation of Pediatric Imaging. Hamza, are you with us? It says that we're restricting unmuting. Eleni? Can't hear you.
Aline, o Hansa pediu para autorizar outras pessoas a compartilharem, aí o Thiago Batista tá como co-anfitrião.
Can you hear me, Hillary?
Yes, yes.
Okay, perfect.
Okay. Can you share your screen?
Can you share your screen, Hansa?
Yes.
Okay, great. Oh, great.
Great. Go to presentation mode.
Yes,
Perfect.
perfect.
Okay, so hopefully you guys can hear me. I'm having some audiovisual difficulties. I'm at another ultrasound course where I'm teaching some hands-on sessions, so I'm logging in during the break. But you can
Okay.
imagine a good-looking guy who sounds kind of nice. So I will get started. Last month, I think Jonathan Samet from Northwestern Lurie Children's presented quite a bit of pediatric osteomyelitis. And I'm not going to get into the same sort of descriptive things about pediatric osteomyelitis, but I wanted to show you some cases where the sequela of infection of the bone in kids can be quite severe. So this is a 22-month-old who wakes up crying at night for the past 2 months, the past 2 weeks, limping. And so if we look at this lateral extra of the foot, there's nothing too dramatic here. If you look at the navicular ossification center, it's kind of small. If you have a really keen eye, you might wonder if there's a little bit of swelling in the midfoot dorsally. We go to MR, we have axial PD fat sat, T1, and T1 fat sat post-contrast images. And again, if we look at that ossification center, we can see it really nicely here. And if you look at the T1 weighted images, it should be bright because that central part is ossified, but it's diffusely hypointense. And then lastly, on the post-contrast images, there is absence of enhancement, and then the epiphyseal cartilage medially is also non-enhancing. We have quite a bit of soft tissue edema and enhancement medially adjacent to the navicular. So this patient had osteomyelitis of the navicular ossification center, which also involved the unossified epiphyseal cartilage. And then we have a sort of a soft tissue infection medially as well. So let me show you another case before we talk about pediatric osteomyelitis. This is a 6-year-old that presented with new onset limp. And initially we have a normal radiograph. Moving on, this is just 8 days later. A patient was having persistent pain and limping, so the radiographs are repeated. And now we're seeing a lytic lesion in the medial metaphysis of this patient. And here's the MRI. So again, we have osteomyelitis here in the metaphysis that's involving the epiphysis and also involving the epiphyseal unossified cartilage. On MR, it essentially shows up as a non-enhancing region within the epiphyseal cartilage on post-contrast imaging. So we can see that really nicely here on these axial images. Okay. Pediatric osteomyelitis, Jonathan talked quite a bit about this last month, but it's hematogenous. It likes to go where the blood vessels are, so it goes to the metaphysis. You will have, like in adults, low T1 and high T2 weighted signal and enhancement. Now remember, kids under age 1 don't have a lot of yellow marrow. So the low T1 characteristics that we see in older kids or adults may not be applicable. And in those kids, you have to use edema of fluid-sensitive images and enhancement. And if the unossified cartilage is involved, typically you'll have non-enhancement of that part of the cartilage where you have infection. Obviously, this can lead to quite a bit of growth disturbances. Now, as you remember, the epiphyses in kids are mostly cartilaginous. And if you look here, we have a small ossification center in this diagram, which grows over time, and the epiphyseal cartilage gets smaller. And eventually, when the kid's skeletally mature, you have articular cartilage and a physeal scar. Also, the other rules to remember about infection in kids is in less than 1-year-olds, there are vascular channels that traverse from the metaphysis to the epiphysis, so you can have infection spreading from the metaphysis to the epiphyses. After one, there aren't channels, vascular channels crossing the physis, so it's less common to have infection go from the metaphyses to the epiphyses. And then lastly, once the physeal closure happens, you again have vascularity that extends from the epiphyses to from the metaphyses to the epiphyses. Now, I want to show you more than infections, some of the potential sequelae of infection in kids, because they have growth plates and there's a lot of growth that's happening at multiple parts of the joints. They can end up with limb length discrepancies, angulation deformities. In the acute setting, they'll sometimes present with pathologic fractures. You can get osteonecrosis of the bone, and so depending on the severity of the infection, sometimes these kids require multiple surgeries for correcting deformities that result from infection. So here we have an 11-year-old soccer player who fell and had a knee abrasion, just presented a week later with swelling and lethargy. So this is not an uncommon history. Sometimes we'll see kids that have very minor trauma. They might just have an abrasion and then they'll present with something like this. So you can see the extent of septic arthritis and osteomyelitis in this kid. We have quite a bit of signal abnormality within the proximal femur itself, but then we have collections along the pelvic sidewall, quite a bit of effusion in the hip, and look at that synovium. It's really thickening and enhancing abnormal. So obvious case of infection, but this is the same kid 4 months later. And if we look at the image on the left, the fluid sensitive image, you can see that this patient now has a slip at the slip capital femoral epiphysis. You can see the same finding on the coronal T1 weighted images. It's usually the metaphysis that's slipping. It's sort of a Skiffy's misnomer, but it's the epiphysis stays in place. It's the metaphysis that slips. But this is slippage at the physis post infection. Here's another kid, 9-month-old with thigh swelling. So it's not hard to see the extent of infection in this kid. Essentially, the entire femur, entire thigh, there's quite a bit of infectious collections in the muscles, infectious myositis, very, very severe. And then this is the course of the disease in this kid. So we look at the x-rays. We have a pathologic fracture initially at the proximal subtrochanteric femur, as well as the distal femoral metaphysis on the images here at the top left. And then these are healing on the follow-up images obtained a few months later. You see some healing, callus formation, both proximally and distally. Looks really nicely healed. And then this patient goes on to again fracture the mid shaft of the femur. At this point, persistent infection, they decide to remove part of the femur and put in an external frame fixation device. And then ultimately that femur is fixed with a lateral plate. But again, there's not a lot of healing going on at that fracture site. And look at the patient now. This is at present time, there's still quite a bit of bowing deformity of the femur and severe leg length discrepancy. There's a 3-centimeter block under the left foot, and the pelvis is still tilted towards the left. So pretty significant sequela of pediatric osteomyelitis. This patient is a 7-year-old with ankle pain for 2 months. And here we can see there's some lucency in the medial metaphysis. You can see it on the lateral film. It's more anterior than posterior. And MR shows pediatric, osteomyelitis involving the metaphysis that's involving the physis. You can see the physis kind of nicely laterally here, and as you get to the medial physis, it's hard to really distinguish it from this collection. So we have a intramedullary collection abscess that's involving the physis, and as you'd expect, there are sequelae of that. So this is the patient's follow-up. We see a pretty big physeal bar centrally, and when you have physeal bar formation centrally, you get limb length discrepancies, which is what we're showing in this lower extremity radiograph of both sides. Now, if the physeal bar is more towards one side or the other, you end up with angulation deformities. But if it's central and it's that big, you will get limb length discrepancies. Here's a 4-year-old with arm pain and swelling. Pretty benign looking X-ray, nothing scary at all. But then you get the MRI, and look at the extent of osteomyelitis in this humerus. Severe, I mean, it's involving the entire humeral bone, a lot of infectious myositis, subperiosteal abscesses on the axial images. And this is, chronic osteomyelitis. Now there's some healing going on. We're seeing callus. And then the end result, severe varus angulation deformity at the proximal humerus, which was eventually fixed really nicely by the surgeons. But a lot of what the surgeons end up doing in these kids chronically is, if they have these sequelae, they're fixing leg length discrepancies or angulation deformities. Here's another 12-year-old with knee pain who has trouble bearing weight. He had a fall, a BMX fall. He was doing BMX bicycle riding. And this was reported as a tibial tubercle avulsion fracture. So if we look at the tibial tubercle, I mean, that seems appropriate. The physis is a little prominent. There may be a little bit of soft tissue swelling there. But the pain was quite severe, so they get an MRI. And then at this point, this was reported as a Salter-Harris 2 injury and some subperiosteal hematoma along the medial aspect of the knee. So that's a little strange. It's a little different than what we saw on the X-ray and what we thought on the X-ray. But then this patient continued with having pain and started having fevers, elevated sedimentation rate, ESR. And so they repeated the MRI. And then now at this point, we're seeing some marrow signal abnormality in the metaphysis and the epiphysis medially. And then if we look at that collection medially, that was called a subperiosteal hematoma, that's growing in size. So this is a couple months later, very, very severe osteomyelitis involving the entire, visualized femur in this field of view. And then we have parts of the bone that are not enhancing on post-contrast images, and they've now become necrotic. So something, quite severe in this patient. At the initial presentation, it didn't seem that way on the X-ray and clinically, but this patient had osteomyelitis that progressed really, really rapidly. So that was my last case. Pediatric infection, it's challenging. It's a time-dependent process, and it can progress rapidly. Because it's hematogenious, we can have multifocal infections. And imaging really helps the surgeon decide, how to progress with treatment. But you have to have a high clinical suspicion to begin with to diagnose some of these. And then the findings are really age dependent. So, not everyone presents the same manner. You have to have a keen eye and a high index of clinical suspicion to diagnose these in the acute setting, so you can prevent some of the severe sequelae that I showed. So that's all I have for you guys. Thank you very much. And sorry about the audio issues.
Thank you, Hamza. I love the cases, the infection cases. Thank you. So first question comes from Dr. Mohammed Gasseb. He wants to, it's from the question is for the first case. Any observation about the fascia planes surrounding intramuscular cysts for Dr. Benetay?
Thank you. It was a good question. Yeah. So the first case actually had history of surgery, and on the MRI, there was actually involvement of both the posterior compartment as well as the medial compartment of the thigh, as well as it has extended beyond the deep fascia of the thigh into the subcutaneous tissues. So yeah, the first one had multi-compartmental, and it has spread through the intermuscular fascia as well as through the posterior deep fascia of the thigh. That may be explained by the previous surgery, I suppose. The second case was well localized, and it didn't extend beyond the posterior, the prevertebral cervical fascia. So yeah.
Hey, I have a question for Hamza. I put it in the chat.
Yeah.
Hamza, can you go back to that last very scary knee case?
Yeah,
I mean, I'm just, okay, I could diagnose infection there, but go back to the previous image where they called it, and in your opinion, because we see this all the time, and I feel like I text you images that look just like this. Do you think the apophyseal growth plate is wide? I think it often looks like that, and you tell me it's normal.
Yeah, I think it's can you hear me?
Yeah.
Yeah, I think in this case it's not really it would be really hard to call this abnormal unless they in the setting of this was a case that I was sent, but this patient probably had imaging of the contralateral side. And so we end up comparing the physes from one side to the other. And so that difference is what they probably call the tibial tubercle avulsion off of. So it's either
Okay.
the contralateral side is available or the history provided specifically mentions tibial tubercle issues.
Okay, so I have one basic question for you. I remember when I was training, uh, we were made to feel like it was really unnecessary. It was really unnecessary if you knew what you were doing to get the comparison limb in a child. Do you routinely get the opposite comparison?
No, we don't routinely get them. We will only get them if there's a concern for something more ominous than like in this case, I would probably not have even gotten it. And I don't think it was read inappropriately at all. I think they probably had a history of tibial tubercle pain or something of that nature is why it was interpreted that way. But overall, this is a pretty unremarkable film. Even the soft tissues are not so, there's not a lot of pretibial soft tissue swelling. And so I think the interpretation here was okay. It's just clinically the patient had signs of infection that were missed for a while. And almost all the cases I showed you there was a delay in diagnosis, either on the part of the radiology department or on part of the clinicians.
Can you go
So
to the next
the
set of
goal
images
was to
on this
just
case?
show how challenging some of these pediatric osteomyelitis can be.
Just go to the first MRI on this case.
Okay.
Forward. Yeah, so I th thought, I mean, would you have been concerned about the marrow signal in the axial image? Or is that just the,
Yes, you could see that there, well, I'm not sure where the Salter Harris 2 fracture is because I reviewed the case and I don't see a metaphyseal fracture anywhere.
I mean,
So
that
what
growth
I'm seeing
plate
on this
looks
film,
widened medially.
yes, the medial physis is widened, so that would potentially be a Salter 1, but a Salter 1 of the proximal tibia is not a very common injury to begin with. And I don't see a lot of subperiosteal hematomas with, non-displaced Salter 1 injuries. So all of those things. And then if you look at the soft tissues on this film, there's, quite a bit of soft tissue edema that's kind of circumferentially on the axial images. And I think it would be tough to make a call of infection at this point, but it's not a clear-cut traumatic injury.
Okay, and was there one more before everything looked horrible? What's the next image?
Yes.
Oh, no, I guess everything looks horrible here. I
Yeah,
thought I saw the periosteum going into that wide growth plate, but at this point, it's quite obvious.
yeah, this place that subperiosteal collection's enlarging and we have, it's looking like infection. The other thing is most of these cases, the progression is really rapid. It's within weeks to a couple months max for most of these cases. And so I think it's just a tough diagnosis in kids and you have to be really thinking about it to get there and working well with your referring providers.
Very, very scary. Okay.
Yeah, I didn't mean to scare everyone. These are not cases that you're gonna see on a daily basis. Just keep in mind I work at CHOP where we see a lot of really sick septic patients to begin with, and because pediatric osteomyelitis hematogenous, if you have bacteremia, you can really just get infection of any bone anywhere. So so these are not typical cases that you'll see in your practice, but what I wanted to emphasize was the sequela of the ones that are missed for a long time. You end up with quite a bit of debilitating growth abnormalities.
Thank you.
There's a comment here. Do you want to read it, Hillary?
Where I don't see.
One characteristic of, it's from Dr. Mohammed Gassab. One characteristic of intramuscular hydatid cysts is that they tend to respect facial planes growing along muscle boundaries rather than through them. This can appear as a clear, smooth margin between the cyst and adjacent structures on imaging, unlike most tumors or abscesses, which disrupt these planes. This subtle detail can help radiologists differentiate hydatid cysts from other pathologies. Do you see it now?
Yes.
And Dr. Bennett, do you want to comment on it, Dr. Bennett?
Yes, actually, I commented on the chat box. Yeah. So I agree. Yeah, definitely. They tend to respect the fascial planes, but maybe I can put my screen. I can share my screen of the first case. That's
Hansa,
due
you have to unshare yours so he can share his screen, please.
Yeah.
Now you can share your screen.
Okay, thanks. Yeah, the first case, as you can see here, it was a multi-compartmental mass. It has extended beyond the fascia, even to the subcutaneous tissue. That's due to the, I assume that's due to the previous, as I've said, he had history of surgery 5 years back. That's when after that he had recurrence and it's been growing since. So that's due to, I think the fascial planes were already disrupted during the surgery. That's why I think the cysts have extended to the beyond the fascia to the subcutaneous tissue. Otherwise, I agree that they tend to respect the fascial planes. Thank you.
Okay, thank you all. I don't see any more questions in the chat box. Thank you all for tuning in today. Next session will be held on November 22nd, and we will focus on sports imaging. Thank you. See you next month.
Thank you, everyone. Bye-bye.